So good afternoon, everyone. Thank you so much, KSOS and Rajiv, for giving me this opportunity to speak to the newly minted ophthalmologists, whom it's always a pleasure to talk to, as they start on this career path with a clean slate on which we hope they will be writing bright and beautiful things. My topic for today is counseling. And I wouldn't be surprised if a few of you at least wondered what I would be talking about, whether I would be counseling you about becoming good postgraduates or about coping skills as you go through your 3 rigorous years of training. But funnily enough, it's neither of this. In fact, what I'm talking about is not with you as the counseled, but as the counselor. And actually, it's about patient counseling. So, what is counseling? Counseling is giving advice, which we hope is wise, good, solid, relevant advice. Of course, to give advice, you need a lot of knowledge. You need to know exactly what's happening. And this orientation is just to sensitize you to the things that you will be dealing with as you go on. So you need a lot of knowledge before you can adequately counsel, just as you need to know all of ophthalmology if you have to take a good history or to know what you should be looking for in an ocular examination. But why counsel? What is the purpose behind patient counseling? The reason is you make the patient aware of his problem. You then increase, if you tell him about his problem, you show him the possibilities, what the treatment is like, what the treatment ensues, what are the possible benefits, are there any risks, are there complications? And when patients are anxious, apprehensive, talking to them. So one of the things you will need for counseling, which you will pick up as you go along by observation, is communication skills. So you make the patient appreciate what he has, what is the problem, what do we think about it, what are we able to do for it, and what are the problems along the way that he might have to experience. I've gone, like Arup was saying, we are old, at least I'm older than Arup in the profession, I think, and things have changed dramatically. When I was a postgraduate in training, all we said was, you don't have vision because it's a cataract. And the patient said, so what can you do about it? And we would say, we'll operate. And then he would ask, but എന്തെങ്കിലും പറ്റുമോ? Will there be problems from the surgery? And we would say, oh, you don't have to worry. We'll give you back your vision. Just leave it to us. This was the old paternalistic approach. But over a period of time, as we got better at our jobs, and as patients became more aware of what they could expect from us, things started going wrong, especially with the media stepping in, expectations running high. And at that time, some of us went to the other extreme, where we painted the worst case scenario. So we told them this could happen, that might happen, and you frightened them. And then he had to be willing to accept all this and undergo surgery. I believe that we have to balance both these. You have to project that you are confident, that you're capable, that you will give back vision, or whatever you're treating will cure him of or relieve his condition. But at the same time, you have to make them aware that though most of the time there are no problems, there are problems, there are issues. And I have, again, this is a technique I've developed over the years, which brings down the atmosphere, the tension in the room. So when they ask me, doctor, എന്തെങ്കിലും പറ്റുമോ? So I say, look, everything has complications. Think about it. You've come to me now, you're going home in a vehicle. Can you guarantee that you will get home? Leave alone that. I'm walking on this floor at the moment. Can I be guaranteed that I will not fall? But most cases you will get home and I will not fall. So there are complications. There are complications to everything. Nothing I can say is 100% foolproof or safe. But we are aware of this. We try to avoid these complications. And that being so, it should be possible for you to get back the vision. At the moment, I'm talking mainly for a cataract, but honestly, it holds for glaucoma, where we have such a problem with patient compliance because they're not aware why they should be using their drops. With retinal surgery, with lasers, we are trying to maintain the vision they have. Very often, we're not able to improve it as much as they would have expected. So, counseling should also moderate patient expectations. I have a patient who has a cataract, but who has a macular degeneration. So then I must make him aware that, or it may be cataract in an amblyopic eye, that you cannot expect the vision in that eye to become as good as the vision in the other eye. Finally, we are treated as the experts, as is often the final word in a patient who is a supplicant, who's come to us for help. And whatever we say often goes. So you have a lot of power. And I can give you examples which could have happened in real life too. Supposing I have a patient with a bad abdominal pain, which could be constipation, could be appendix. Now, if I want to do an appendectomy, I could counsel him saying, look, this is probably just a constipation, but it could also be an appendicitis. And if it were, it might cause an abscess, it might rupture, you might get peritonitis, which is really, really serious. And then I say, but you decide whether you want the surgery or not. Or I can, to the same patient, say, look, this is probably only constipation. Let me give you an enema. And if that doesn't work, we will rethink, and probably you might need an appendectomy. So this is me talking, whichever I say, the patient is being swayed by me. So what I'm asking all of you is to be ethical, to be empathetic, to put your heart and your mind together, to be on the side of the patient, and to counsel the way you would if it were for yourself or one of your families. Because often it happens that I see patients come to me who have been advised cataract surgery and who have been told that if they didn't do the surgery, it would become hypermature, that it would complicate. And sometimes, or rather more than once, I've had these patients improve with glasses, and they never tell me that they were posted for cataract surgery. So after I've prescribed the glass, the patient says, Timiranda. And I say, why do you ask that? Your vision is good. It's 6/6 N6 even. And they say, Allah, Timiranda. So then I say, look, തിമിരം എൻ്റെ കണ്ണിലും ഉണ്ട്. ഒരു പ്രായം കഴിഞ്ഞാൽ നമുക്ക് എല്ലാവർക്കും തിമിരമുണ്ട്. അതിപ്പോ തിമിരല്ലല്ലോ, നമ്മൾ അതിന്റെ കാഴ്ചക്കുറവാണ് ചികിത്സിക്കണേ. കണ്ണട വെച്ചിട്ട് കാഴ്ചയുണ്ടെങ്കിൽ why should you bother? And then he brings out his medicines and a paper saying that he was posted for cataract surgery 2 days hence. Very often, I have not known where to look or what to say. But now my standard answer is, look, this was not the doctor who told you that. This was the professional counselor who has been taught about the complications, but who has no idea of the level of your cataract. I'm sure that someday you will need cataract surgery. And probably the reason why they told you this was because if you got it done early, you would have that many years of clear vision. That is one situation. The other situation, which I find upsetting with cataract surgery counseling, is that we often advise the higher end lenses. This again, the counselors have been primed into pushing for the higher end lenses, the lenses that cost more. And of course, the higher end lenses, the more costly lenses, have their advantages. I will never run them down. But across from them is a patient who really cannot afford it, who having to buy this would cost him a lot on the home front. There, I feel it's not fair. And it sometimes cuts very badly, because I had a patient with financial reverses. He was a well-to-do man, and then he had financial reverses, and he was brought to me by a friend, a mutual friend, who asked, could I do anything for his cataract? Of course, I was not operating at all, but I referred him to a colleague who very kindly not only operated without cost, but actually put in a higher end premium lens, which had been given to her as a sample. The patient was fine. He had some diabetes. We worried about whether he would have more of inflammation. He did excellently post-op. The vision was 6/6, as it often is on day 1. But 6 months later, when he came for cataract surgery in the other eye, when he still couldn't honestly afford it, he insisted that he pay for it. And I asked him, why? Do you have problems with the other eye? And he said, ഇല്ല, അത് എന്തോ ശരിയല്ല. അന്ന് വെച്ച ലെൻസ് അത് ശരിയായിരുന്നില്ലല്ലോ. അത് ഫ്രീ ആയിട്ട് വെച്ചതല്ലേ. So this is the other thing. You put before them who can't afford the higher end lens, and then they say we can't afford that, and then they opt for the lower end lens. But in their mind, it's not a lower end lens, it's an inferior lens. So the lens that you first offered was the good lens. The lens that he was obliged to accept was the poor lens. And here again, patient satisfaction comes down. They always feel that they've been shortchanged. They feel sorry that they had to make do with less than not. So here again, I have an analogy. I say, look, if your aim is to get from Calicut to Bombay, you could go by bus, you could go by a sleeper class, you could go by air condition, you could fly. But ultimately, you'll get to Bombay. And getting to Bombay is getting back your vision. But along the way, if you took the flight, you'd be there in a couple of hours, absolutely fresh. If you took the bus, you might have a backache, you might have problems. So my answer is, isn't it true for everything? If I want to buy a sari, if I want to buy a shirt, don't I buy what suits my pocket? In the same way, none of us would put inferior lenses into the eye. All these lenses were meant to help you to see, but all of them, as the price goes up, the quality of the lens, like in a camera, the price of the camera is the price of the lens in the camera. You might see slightly better, but I can't say how you would see with the other lens. So if all you want is from not seeing to start seeing clearly and to read the board, let me assure you that all these lenses are equally good. So I will